Welcome to the Hands of Change podcast. Hi, my name is Kurt Harrington. I'm host of the Hands of Change podcast, where we discuss and navigate the complexities of Dupuytren's disease and related fibrotic conditions. From personal stories of resilience to expert insights and new research, the Hands of Change podcast seeks to integrate Dupuytren's information on a common platform encompassing patients, treatment providers, and researchers. Hello, and welcome to the Hands of Change podcast. I'm extremely excited for today's guest, Dr. Keith Denkler. Keith is a distinguished plastic surgeon with a fellowship in hand surgery and has over 4 decades of experience in cosmetic and reconstructive surgery. Dr. Denkler serves as a clinical professor of plastic surgery at the University of California at San Francisco and has a private practice in Marin County. Keith is internationally renowned for his expertise in Dupuytren's disease with a focus on minimally invasive procedures. He has treated over 10,000 Dupuytren's fingers, authored over 35 publications and book chapters, and presented internationally and domestically on Dupuytren's disease. I have had the pleasure of knowing Dr. Denkler for several years, and I'm grateful for him joining the show. I hope you enjoy it. Well, thank you very much for joining and being part of this discussion. I'm excited to have you on. I think the folks that are going to hear this on the rebroadcast are going to be delighted to hear from you. You're obviously a leading name and voice and pair of hands in the industry. So on behalf of the many patients that know your name in a positive light, as I do, thanks for doing this and sharing your experiences. So Keith, if you don't mind, I always start with my guests just talking a little bit about their backgrounds and how they ended up working in surgery, and then more specifically, how they ended up working in the area of Dupuytren's, among others. I know you work in a lot of areas, but with a focus, if you will, in Dupuytren's.
Okay, fine. I'd like to introduce myself. My name's Keith Denkler. I'm a physician in Larkspur, California. I have a private practice here in Marin County, and I have a professorship, clinical faculty at where I teach at UCSF, University of California, San Francisco. I'm from the Bay Area. I grew up in the Bay Area, but in high school, my father with Shell Oil was transferred to Houston, Texas. So that's how I ended up in Texas. And I went to high school in Texas, but then in my junior year, I accepted a scholarship to South Africa for a year, and I lived with an eye doctor there, and I became interested in medicine. My father was a patent attorney, so I grew up in an engineering legal family, but I became interested in medicine. And then when I came back, I applied myself, went to University of Texas undergraduate, hook 'em horns. That's my school in Austin, Texas. And I studied there for 3 years, and I excelled. So I got in advanced early acceptance, went to Baylor Medical School. I studied there from 1976 to 79. And then I did a rotating internship with the University of Texas system in Houston. Took a month elective in plastic surgery, and it turns out the leaders at St. Joseph Hospital in Houston there were world-renowned for cleft lips and palates. Dr. Cronin invented breast augmentation, the implant, and so they did a lot of those, and he also did cleft lips and palates. Dr. Benjamin Cohen would sew fingers back on. Dr. Larry Lawrence Wolf was a preeminent surgeon, had lots of expertise in lasers. And Dr. Ernest Cronin was an ENT plastic surgeon, and he had lots of facial analysis. So and techniques and nose jobs. So I became interested in the history of plastic surgery, how variable it is. Plastic surgeons, we operate in the young and the old, the rich and the poor. In hand surgery, we take care of burns. If you burn your hand, you don't go to a hand surgeon, you go to a plastic surgeon. So we take care of the skin and the nerves, and we sew fingers back on. So that's how plastic surgeons are. Most of my practices, of course, plastic. I had a fellowship in plastic surgery in Paris, France, and I had a fellowship at UC San Francisco in hand surgery. And so when my wife and I came to San Francisco to seek out a physician, we left Austin in a U-Haul and with her stuff and our stuff, and we came to San Francisco. And then she joined Kaiser Permanente, and I joined the UCSF faculty, where I still remain as a academic volunteer faculty. And so then we opened up a practice together, and we practice here. So we've been practicing here in Larkspur for 35 years and married for 39. So women say that's a very good sign that you can
That's
work with your wife.
the dynamic duo. I love it. I love it.
But we have a great practice together, and we enjoy each other's. We've co-authored several papers. We actually have a co-authored paper coming out next month, a new innovative treatment for bee stings. So that'll be out next month. I can't really spill the beans in that because it's not published yet, but we're excited
Fantastic,
about
though.
that.
Accepted and going
And
to
we've
go.
written some articles in the history of cosmetic surgery. And I'm actually working in another big article in that too, tracing the history of cosmetic history from ancient times to basically up till 1900s and World War One. So I came to Marin County, and I was, of course, trained in Dupuytrens, and I knew about Dupuytrens, but my county, Marin County, has a lot of Northern Europeans, and it's an older community. So the average age of Marin County is over 50. So Northern Europeans over 50 have a lot of Dupuytrens. So I started treating a lot of Dupuytrens, and of course the traditional treatment was wait until it gets bad, maybe 30 or 40 degrees, positive tabletop test, and then take them to surgery. And that's what I did. And since I was the first plastic hand surgeon in fellowship trained, and even I was certified I got board certified in hand surgery for 10 years. I didn't renew it, but I did obtain early certification, but it's not necessary afterwards. But I decided not to renew it and go through all the testing. But I started dealing with a lot of Dupuytrens, and the first innovation I made was I thought it was ridiculous to take people to surgery to make a cut that's maybe an inch or 2 or 3 inches long, because I can repair a chainsaw laceration to the knee, to the thigh in the ER under local. Why should I have to do that? So I started working with using local anesthetic Dupuytren surgeries, and I actually published that in 2005, showing how Dupuytren surgeries could be performed wide awake without the risks of general anesthesia. And so that was an early publication. I was, of course, doing those cases in the 90s. And when I was giving a talk, I think in about 2003, UCSF, I was talking to Dupuytrens. And so I Googled Dupuytrens, and I read about what Dr. Eaton was doing and Dr. Lermousseau and Badois in Paris. So I decided to, I was interested in that technique, and I had to convince my wife to go to Paris for a week.
Tough sell. Tough sell.
It wasn't tough. Of course, I'd done a fellowship in Paris, so we speak a little bit of French, and
not a week in Paris.
There. So we did that, and I spent a few days with them to kind of learn the needle technique, and I started the needle in 2005. So I was first on the West Coast, and then I was on TV for that. For Dr. Dean Adele used to have a television show, and he invited me to show a live one on camera. So that got interest.
Wow.
KGO goes from LA to Alaska, so and nationwide even. So people from all over the country, and especially the West Coast, started coming to me for needle. And after I was doing needles and became busy in it, I realized that it was much nicer for the patients and less complications than the surgery, even though it's blind. But I feel like the fact that I'm sticking needles into people's hands doesn't scare me, because I do play string instruments, cello and violin. So I'm used to playing a cello without frets.
Right.
You don't, and you find it in space. So I can operate by feel, not just by vision. I mean, I look at where I'm going, but you can also go by feel and understand what's happening in the hand, and you can feel the chords and nick them. And so it's a kinesthetic and feeling technique.
Okay.
So then I started writing up some of my experiences, and I have done that, and I've given multiple conferences. Mostly my emphasis has been to educate hand surgeons, speaking of the Society of Hand Surgery and the Association of Hand Surgery, and lecturing at various medical schools like Oregon Health Science Center and Stanford and UCLA. So I've enjoyed that. I was thrilled when Xiaflex came in the market, and I was one of the earliest people to use Xiaflex, because Xiaflex has a great use, especially for people that have had surgery before.
Okay.
Because after surgery, it's difficult to do a needle because there's more, it's not such a defined cord. It can be sort of three-dimensional scarring. So I've enjoyed using Xiaflex to dissolve the scar tissue and to dissolve the cords, and it spares nerves. So I find that very, very useful. In my practice, I mostly do needles, and then I do some Xiaflex. And currently, I'm not doing surgeries anymore. I refer them to my colleagues at UCS now for some people in the city, or even there's a new highly trained hand person locally. So because my skills are very much with the non-surgical technique, so I think I decided to just emphasize that.
Right. Okay.
So, and then my publications, I've used Xiaflex. I mean, one of the complications of Xiaflex is that it can eat tendons. And yes, I've had two in the past 15 years, but I've done, more than 1,000 fingers, and those were early in the experience, and I've not had any in a long time. When you're using Xiaflex, it's important to do you can use the medication laterally, where the tendons are centrally, so you can use it laterally. And I've also published a paper on using Xiaflex to dissolve the tendon. Like a boutonniere, the tendon's too tight, so you can eat it distally instead of cutting it. And that was an innovative paper, and got some prizes for being a best paper. I've also written up my experience in 204 needles on people with stage 4 Dupuytren. So basically, they have more than 100. Well, they had on average 150 degrees of bend.
Wow.
And so I did a needle on them, one needle, and I followed them up. If they came back for surgery or enzyme or another needle, they left the study, and I recorded their measurements. But I have one person who's more than 20 years. He's still straight after one needle.
Wow.
So my teaching is start with the needle. You can always do more later.
Right.
You don't really burn bridges. And those who are afraid to learn needle, the Xiaflex is a good first start also. So my teaching is start at the bottom. I generally start with a needle. And if that's successful for years, I just repeat the needle if it recurs. If it comes back in 6 months or less than a year or less than 2 years, I will usually switch to the enzyme. And I can go back and forth with those before I submit someone to surgery. And so my practice is heavily in the non-surgical treatments,
which we love, and you're so well known for. So thank you.
I do enjoy it. It's great to get people's hands back. They can feel their hand is like it's supposed to be. Yeah. I mean, when your hands are curled up and you wash your face and you poke your eye, or you're trying to brush your grandchild's hair and you poke their eye, it's disabling. Golfers are less troubled like it because they can still hold the golf club,
yes,
even with bent fingers. But that's another story. But non-surgical techniques can get the fingers pretty straight, and you don't have to be out of golf for maybe a few days or a week or so.
Right. Yeah, I was going to say, how do most patients find you? I know the ones I know that know of you are finding you through the patient community of a Dupuytren's expert with tons of experience and a patient advocate. Are other patients referred to you, or are any referred to you from primary care or rheumatology or derm or other areas, or is it all patient driven, if you will?
Correct. Local dermatologists, family practitioners, and even some surgeons, hand surgeons, will send me some of their tougher cases because they realize how hard it is to do surgery in some of these difficult cases. So I will get some difficult cases. I had a great patient. He'd had surgery at Stanford on one finger. He had surgery at Stanford in 2007, 2012. A UCSF microsurgeon did surgery in the same fixture in 2009. Last month, I did Xiaflex on him, and he's totally straight. He was so happy because he'd had 3 surgeries by top surgeons, top institutions, and it still was like 90 degrees. So it's interesting that works. So people sort of feel like, oh, you just need a better surgeon. However, when top surgeons are doing it, it can still fail. So my teaching is, let's start small and work yes. our way up and save the biggest techniques for later. One of the problems with surgical fasciectomy or surgery is if you do a surgery on the little finger, you may be in rehab for some weeks or months or even longer.
Right.
You get, on the other hand, you're in surgery, you're in rehab for some weeks or months or even longer. Then the other finger comes back and you start adding up the months and months of rehab and how much life do we have left. It's a lot of time in rehab. And
Yes.
and then surgeries can fail. I mean, I participate in some of the communities that, communities and just try to help patients because I do have a strong helping aspect to people with Dupuytren's, and I have great knowledge, and I don't mind contributing.
No. Well, you have a wonderful heart, and yes, I can personally attest to how responsive you are with questions like that. And when I reach out to folks from around the globe now, your name is usually always known as somebody, oh, we consult with him or we reach out to him or whatever. So thanks for your dedication to the space and to us. The data suggests the recurrence is usually less with a fasciectomy than a needle or Xiaflex. But what I was thinking when you were talking about it, some of the success you're seeing, how much of that is technique and maybe disrupting the area less, therefore to potentially reduce the immune cascade that might happen after and exacerbate recurrence.
Well, getting out chunks of the disease with fasciectomy is excellent. And you like that because you're cutting out chunks of the disease. The disease is internal, but that segment is gone. However, the failure rate with surgery at 5 years is 20 to 25%. So 1 out of 4 is going to have a problem. Plus, they have the added surgical scar and the tight skin. Now, however, I view recurrence differently because if I do a needle in 5 years, 85% are going to need treatment. It, quote, recurs. And that means it comes back another 30 degrees, 20 or 30 degrees from when I started. And now that's fine. 85%, that's high. However, 15% are golden. They don't need any more treatment. They're happy campers. They're gone. So 1 out of 6 are gone, and it was a success. If you'd done surgery on all those people, 1/6 of them would have done fine with a needle. So why not get those people out of your database? Do a needle, 1/6 are gone for 5 years, and they're happy campers. Great. However, the 85% that have recurrent disease, some are going to come back at 6 months or within a year, and that's a small percent. That's maybe 10% or maybe 15%. And they're coming back in a year or so, fine, try the enzyme. Another 15 to 20% or 30% come back at 2 years. And at 2 years, they kind of don't mind doing it again. Okay, let's just do it again, doc. I'll do it, see you back in a couple of years. I mean, when you clean your teeth, you come back every 4 months because your teeth go bad. You can laser the teeth, but you still need, come back every 3 more. So Dupuytren's, if they come back at 2 years, or if they come back at 3 years, maybe another 30% come at 3 years. It's not hard to have a needle every few years because it's not a bad recovery. And some come back at 4 or even 5, and you can do a needle again. So recurrence is not like, oh my God, it's got an 85% recurrence. Well, yeah, that's at 5 years, but how many are coming back at the first year? How many coming back at the second year?
Right.
And in terms of getting rid of the tissue, what's fascinating, and there's excellent data coming out of Europe where they compared needle to collagenase. And collagenase dissolves tissue, but the results with needle are essentially the same with collagenase and needle. Needle just breaks it up, but it's all there. Collagenase eats segments, but why is the recurrence so similar? I don't understand that, but that's for the people with scientific bent. I'm scientific and I'm clinical, and so I have clinical scientific. I'm not a research scientist. My Dr. Worker, who I know well and has stayed with me when he's attended meetings in San Francisco, he researches the DNA and all that stuff's outstanding. He's done outstanding work in Europe. I think that's his group of people there are outstanding. There's a big conference coming up in Brussels this June, which is very exciting, where Dupuytren's experts from all over the world get together every few years to it's about every 3 or 4 years. So I'm very interested in that. I will watch it and work out to watch it in Zoom. I'm not going to be able to attend because that's a busy, that's a teaching month at the
Right.
university. So but I'll watch it in Zoom, and that's great.
Fantastic.
So anyway, so that's sort of my research papers, and I am interested in the research. I do want to let people know that you can Google Dupuytrens, and then you can look at the news on Dupuytrens. You can look at websites on Dupuytrens. You also can go to Google Books on Dupuytrens, and then you can look at all the articles on Dupuytrens. But if you also segment it and say, I want to look at all the articles before 1900 or 1920, you can actually read those papers online for free because they're not copyrighted up till about 1920, 25 or 26. So you can read those, and it's fun to read those as the doctors were trying to work with iodine.
Oh my gosh.
They were inserting fat grafts in the tissues. I've tried fat grafts. I haven't found it useful. I mean, when it came out 10 years ago, we thought this was going to be great, but my experience is it's sort of fibrosis, and we thought it would interspace between a needle, but my experience has not been great with it, and so I'm not doing it. I've also tried injecting Restylane and Juvederm in there as a spacer, and I can't say I haven't published that, but I can't say that that's had any effect.
And do you
I did publish a paper on Botox for Dupuytren's, and one dermatologist injected it into the Dupuytren's, and that took away the pain. I've injected it into the cords. I saw no effect in the cords.
Okay.
But I did publish a paper where I used it where a patient had a 90-degree finger contracture, and I realized, when you straighten the finger, you're going to have muscle memory. So I injected Botox into his forearm muscle to relax the muscle that bent him down during his recovery, so he didn't have to fight the muscle memory.
Wow.
So that has a useful, nobody's really picked up on that because it was published in an obscure journal, but it's an idea that when people have really bent fingers, you can put Botox proximally, weaken the muscles. There's two muscles that bend your finger, there's two muscles that flex your finger. So you can weaken one of those or both with Botox to release the muscle memory. So people, when they have bad, it's obviously it's an added expense, but it's some hundreds of dollars. It's not like
right.
a surgical procedure. I mean, my daughter-in-law had a surgery, is $40,000 for a finger bone pinning for a day surgery.
Oh.
But it's some $100, but it's useful because you can release muscle memory proximally.
Okay.
And that's interesting, and that's fun. I try to do. I'm still innovative with all this, just like with the bee sting article which comes out. I'll send you that paper when it comes out.
Awesome,
Kurt. But it's good to be trying to. I'm trying to take stuff that we have and use it. I have used 5-fluorouracil, which is a cancer agent. I've tried other cancer agents, haven't had really success with it. So there's no silver bullet yet, but we're all trying to work to help people. And of course, with Vento Biosciences, I am an advisor there. We're trying to come up with new innovative treatments also, and testing that in the lab, and hopefully that will continue to be successful, and we can help people.
For sure. Are you using anti-inflammatories or prednisone or corticosteroids much?
Well, there was Dr. de Greef in Brussels published a paper on celecoxib, which is a CLECOX. It's like an Advil, but it doesn't affect the stomach. And she gave people that after Bioflex and found it helped the results. So I think I've always thought that would work. I haven't quite incorporated in my practice because it just came out like a month or two ago.
Right.
But I think that's pretty easy for people when they get treatments to. She only put them on for about 10 days or 2 weeks. But if you can get some improvement, that sounds good. And then Dr. Benheim, who was one of my students at UCSF, and I taught him the needle back in 2007. And he's a top needle guy and top Dupuytren's guy at UCLA. But he was giving people prednisone in the injection, which
Okay.
we used for a needle. And I just saw recently Dr. Abe, ABE in Japan, was giving people short doses of prednisone after he was treating their Dupuytren's, and they had success. So I haven't incorporated that. That's all fascinating. Obviously,
Prednisone post
the
NA.
easiest one would be the non-steroidal anti-inflammatory versus steroids, but this is all exciting stuff. In scar tissue, we inject cortisone, and it helps in Dupuytren's, but it's not a silver bullet. Of course, I do use Kenalog or something like Dupamedrol to soften nodules and use it for early Dupuytren's, and it has some benefit in needle also. I have not used it after Xiaflex yet.
Okay. What about, I know I personally have had radiation a few times. Does that impact or change your ability or your options around how you might treat a patient? Whether if the patient's been pre-treated with radiation? I know for my procedures, I've had it after, but like after an NA.
Well, the good news is radiation for Dupuytren's is low dose.
Right, right.
As a plastic surgeon, I reconstruct breasts that have had high dose radiation to kill cancer. So plastic surgeons, we treat people that have had heavy doses of radiation to the face and the body. It can delay wound healing. So if you get a wound or if you get a skin tear, it can take longer to heal. It does inhibit healing. And I think it's good. I mean, obviously the studies are coming out on radiation therapy. I think it's been mostly positive, although it's a little difficult to measure its effect because not everybody necessarily gets bad anyway. I'm fine with radiation. My role is to get the fingers straight so they can be radiated. So
right.
If you have crooked fingers, you need to be straightened. And basically my approach is let's straighten your finger and see how long they stay straight. If they come back at 6 months or a year, let's get your finger straight and get your radiation. If it comes back at 2 or 3 years, well, maybe we just see every two or 3 years.
Love it.
But I seriously, when I was in college and medical school, I did radiation research at MD Anderson Hospital in Houston. So I know about radiation, and overall it's positive. And to a degree, it's a surgical knife, and I'm positive. I'm positive with it. And Dr. Schmidt has done outstanding work in Germany, getting that on the table. Even our local radiologist at my Marin hospital use it. And of course, Dr. Gottschalk at UCSF is a noted expert, and Dr. Poen at my local hospital a mile away, he's doing it. So all of these things are good. So it's beneficial to patients.
Right. I love it.
I believe it's beneficial, but how much, when to do it, that's still all being sorted out.
Right. How many times?
I'm positive on it. I'm not against it. It definitely has a role.
Awesome.
What I like to say is radiation damages growing tissue.
Right.
The only thing growing in your hand is Dupuytren's. And if you use it for a breast cancer, the only thing growing in your breast is a breast cancer. So they kill things that are growing. So it's sensitive for growing tissue. And the good news is they sort of touch it in the hand. So in terms of causing cancer, no, I don't believe so. You can get some side effects like dryness and things like that, or maybe some fibrosis. Maybe that can happen. In terms of treating, I treat people afterwards. I've had people that have had radiation. I still have to do needle. I still have to do some enzyme. I don't believe I've had to do surgery or anything. But when someone really bends a lot after radiation, I think it's harder. But I remember one woman, she was bent about 90 degrees even after radiation, and I got her straight, but it just came right back and bent her down. So that's highly disappointing, but that can happen.
What are the most common questions you get from a new patient that's considering the needle? Since there's so many patients that listen to this, what are the most common questions you get, and what do you tell folks in terms of concerns or expectations, whether it's, in the procedure, or I see a lot, how soon after can I work, and can I use my hands, and, can I ride my bike a week later? How generally cautious should they be with their hands and things like that?
Basically, after a needle, the recovery is pretty fast, within a week or so. I mean, obviously, if it's a more severe Dupuytren's that I'm doing a needle on, that has a longer recovery. If the skin tears, that can encumber healing. But most people have more minor stage 1 or stage 2. It kind of knocks them down for a week. They don't necessarily need much follow-up. They don't necessarily need therapy because it's not a painful process. You can take some Advil and you can kind of work straighten straightening your fingers. So basically, you're from bike riding or tennis or golf, you're kind of talking maybe a few days to a week or two. For the enzyme, it's a step up. It's more like a couple weeks or maybe longer, and a skin tear can hamper that. And then surgery, that can be weeks. Or some people get pain syndromes or delayed healing, and they could be in rehab. I mean, some people are in rehab. And the disappointing thing to me with surgery was I could do a nice surgery and the people could recontract in the healing despite therapy to what they were before. And that was so disappointing. If that happens after a needle or enzyme, they haven't burned that much. They haven't really burned bridges. And wow, this is going to be tougher, and this is going to be a tougher surgery and a tougher rehab. So that's one of the reasons I was thrilled to go with a lesser technique.
Yes, for sure. Absolutely.
And so basically, I can't predict. If I see someone with early disease, I tend to do the cortisone.
Okay.
Generally, I use Kenalog, although some people have been asking for Dupuytren, which is essentially the same. I don't see much different.
Okay.
The recovery is pretty fast. If someone has really bad disease, and this is important, there's a tool called a digit widget.
I've seen it. Yes. Okay.
DIGIT widget, WIG widget. That comes out of Sacramento, California. Dr. AG invented it. It's a great invention. But basically, you're putting pins in the finger and then turning the screw like the torture rack every day for some months. And then you take out the pins and do surgery, or a guy in Italy did Xiaflex. My approach to that is I do a needle. I've done needle for severe fingers, and they generally, after a needle, they gain 100 degrees if they have stage 4 severe disease. They gain 100 degrees immediately, and in 2 years, it's maybe 90 degrees on average. So I do a needle first, and then when they're straighter, you can do a surgery. But most people, when they're down 150 degrees and you get them to down 60 degrees, they're kind of, or 50, they're kind of okay with their hands.
Right.
And they don't go for surgery. But I haven't used the digit widget. And of course, the digit widget, when you put pins in the bone, you can get pin infections and bone infections. So that's how I approach severe disease. I tend to do it with severe disease. I tend to do a needle first, and then I follow up with the enzyme.
Okay.
Because I didn't like doing needle, but the enzyme's useful. In terms of payment, when you do a needle or do surgery, it's a 90-day follow-up, so you can't really do something else during that period. So if you want to do a needle, on the other hand, you have to wait 90 days, and that's true for Medicare and most of the insurance companies. With an enzyme, you can do an enzyme on day 0, you can do 30 days, and then 60 days. So you can do 3 treatments of enzyme in 60 days. So 60 days. So if you have someone with a lot of fingers, you can get a lot done in just 2 months.
Okay.
But that works for billing and how the insurance companies and Medicare cover it. But I like both. I mean, individualized. I tend to favor the needle because I'm good at it and it's fun and it's immediate.
Yep.
Although the enzyme is highly useful. Historically, the first needle was done in 1805 by Dr. Klein Jr. in London. His dad had speculated in 1777 that a fasciotomy or a needle would work. So his son did a fasciotomy in London in 1805.
Wow.
There was a doctor in 1822 in London that wrote about it. Dr. Cooper wrote about it and talked about a fasciotomy. The French, in their textbooks in 1814, thought it was a dried up tendon and didn't have much solution. Dupuytren knew a wine merchant. He's in the wine business.
There you go.
He probably liked it. He fell off his truck. One of the Dupuytrens fell off their cart, and he cut off their hand and died. So he cut off their hand and dissected it in the lab.
Okay.
So he gets the credit for it, even though the English knew about it and wrote a letter to the Lancet and said, we already knew about this.
Right.
And Dr. Cooper and Dr. Dupuytren knew each other. But anyway, the French got the name. Then, curiously, in 1845 or 1848, a doctor said that abstaining from alcohol helped. Alcohol has a role in the disease, but it doesn't mean you're drinking too much. If you're drinking more than 3 drinks a day, that's too much and it's inflammatory, and Dupuytren's tends to get back. But if you're having 0 to 1 drinks or 1 or 2, that's in the range also. So heavy drinking is bad for Dupuytren's. Diabetes is bad, and vibration. People that work with a jackhammer or vibration, but it takes years of exposure.
Right.
If people ride a bicycle, obviously a road, there's a lot of vibration there. So I say, well, enjoy the bike, wear padded gloves.
Yes. Yeah. For me personally, it was a personal preference, but I love it for my Dupuytren's as well. I used to always ride a regular road bike where your hands are on the handlebars the entire time.
Yes.
But 5-6 years ago, I got into triathlon, and they have those aero bikes where your elbows are in those little slots and your hands are out in front, which
Yes.
it's much more comfortable for me to ride the bike that way. It's faster too, but I feel like
That's
it's
a
a
good
lot
idea.
better for my Dupuytren's because I can hold the bars loosely, aside from crashing once last year, and ideally not have as much vibration. Have you seen a lot of folks that come in that are motorcycle riders and things like that with the vibration on motorcycles?
No,
Or okay,
not at all. And
okay,
not at all. And but I do want to talk about comorbidities. The
yes,
one comorbidity that's somewhat common in the Dupuytren's group is trigger finger.
yes.
Now, trigger finger is basically scarring around the tendon that causes impingement, and the tendon catches. People with Dupuytren's get added scarring and growths in their palm, and so there's a higher percentage of people with Dupuytren's that get trigger finger. And sometimes it's just pain down there, and sometimes it locks, and sometimes I'll pick that up. And so people, and if you do surgery on Dupuytren's, it can bring out a trigger finger, and the recovery is a lot tougher. I wish that's something that needs to be studied, how well people with trigger fingers, I think, do worse after Dupuytren's surgery.
Interesting.
And so that, because I have my own patient where I did his trigger finger, and the Dupuytren sort of erupted locally afterwards. I took quite a bit of cortisone injections to settle it down.
Wow. Okay.
Because trigger finger is sort of an inflammatory tendonitis. Trigger finger is a tendonitis, but it's inflammatory. There's some sort of inflammation that starts and sets the process. I'm excited about of course, Humira, which is a anti-inflammatory arthritis drug for early use in Dupuytren's. I believe it's in stage 2. That has a role. I mean, the question is, can you do a needle or enzyme, get people straight, and inject Humira to keep it from coming back? I mean, that needs to be studied. True, and even with our own drug, once it's out there, can you inject it after treatment to prevent it from coming back?
Reduce
because
recurrence.
People will present with contractures that need treatment, and some you can catch early and prevent it. Yeah.
Right, for sure. What about, you mentioned trigger finger, which I hear a lot about. What about other ones I hear commonly either kind of predisposing Dupuytren's is post adhesive capsulitis. Somebody hurts their shoulder or has a shoulder surgery. And I also hear carpal tunnel. Somebody had a carpal tunnel surgery and then their Dupuytren seems to pop up after. Are there other common ones like trigger finger that you see for patients in your practice that the Dupuytren's may have appeared after an upper limb?
Well, I don't know much about adhesive capsulitis of the shoulder, but it is somewhat common. It's associated with Dupuytren's, just like lederhoses and, of course, Peyronie's. I think the solutions are, they do Xiaflex in some adhesive capsulitis, or they kind of break up the scar under anesthesia. Company Endo Pharmaceuticals is doing work for Xiaflex in the foot, which could sort of dissolve the big nodules. That may have a role. The only problem, I think, when you walk in your foot, this has Xiaflex, it's going to hurt.
Yes.
Whereas people that get Xiaflex in their hand can elevate their hand, and that helps. But all of this is good, and we don't quite know the association.
Right.
Curiously, Dr. de Grief in Brussels, she gave people after surgery an estrogen blocker, tamoxifen, and that took away the Dupuytren's. It didn't come back, but the men hated it, and when they went off it, it all came back. But there is somehow estrogen may be protective, and testosterone with its gnarliness is too much, makes the Dupuytren's grow. There's a relationship there, and I'm happy for the scientists to keep figuring that out for us clinicians.
Same here. What about the future of NA? Obviously, you're renowned, and I think you treated probably over 15,000 hands by now. It was 10,000.
I say 10,000.
Right.
10,000 fingers.
Is
Because
sufficient.
some hands
10,000
will have
fingers.
2 or 3 fingers. I mean, for Xiaflex are the same, probably 1,500 or
It's
2,000. I don't
amazing.
know.
It's
I don't
amazing.
I don't keep track of that anymore. But I've been doing Xiaflex for almost 15 years, and I've been doing needle for, God, I started in 25, so it's been almost 20 years. I mean, most of my practice is plastic surgery. 10 or 15% is Dupuytren's, and I'm happy to take care of the people.
Do you see
And some days I do Dupuytren, some days I do a facelift all day. So it's it doesn't matter. I'm happy to be helping people and helping them with their issues.
which you do? Do you see NA in terms of training future surgeons, other hand specialists to do it? Is it part of residency programs or major hand conferences, whether it's ortho or plastic, or do you see it as hopefully growing in terms of making additional Dr. Denklers?
Well, I teach at the medical school, and I teach the students that, and they can come up, and obviously we get some visitors sometime, and I do speak at conference. I think the trend is that surgeons get timid about needles in the fingers, and the trend is to using more Xiaflex,
Okay.
because Xiaflex avoids, with needle to the hand. Sometimes you can ding a piece of the nerve and can kind of get electric shocks for a while. Generally, it recovers. Xiaflex doesn't. Tendon ruptures are very, very low. And of course, the Xiaflex is a lot faster for the physicians. I mean, you can plan a 15-minute visit and then maybe and so it's more scheduled. But sometimes needle, it can take longer, so it can throw off the doctor's schedule. So
Okay.
the trend is for more Xiaflex and less needling, and I think that may
And is that due
continue.
to the how much of that is due to the flying blind element of it, which is different for most other procedures versus the office throughput and things like that? Is the blind procedure element?
Well, yeah, surgeons get timid with a blind procedure element, yes,
Sure.
and so the Xiaflex takes that away.
Okay. Makes sense.
So that's why I think in the future there's going to be more of that, and you
Okay.
can and it's it's more efficient from a time standpoint.
Right.
I mean, Dr. Benheim mostly just does Xiaflex now because he can schedule it and take care of more people at a busy medical center like UCLA.
Right.
Although he's highly trained in it. And like me, sometimes when I do a Xiaflex, it's an incomplete straightening, and I will sometimes do a needle for the residual, even though they're numb, because you can do some needling on a numb hand, which is also taught. So that can be useful. 90% of the time, I don't need to do any needling, but I will sometimes because it can be extra benefit.
Right. Okay. And then quickly for the folks listening, the in-office procedure for NA, if it's roughly how long do you see it taking? Can you just describe kind of the process for you for the folks that might be considering an NA or a needle?
Well, if it's early disease, if it's 30 degrees and it's the MCP joint, or even if it's 40 or 50 degrees and it's the first joint in the palm, that does very well with needle. It's a great way to stop. It's the safest. People are happy. It's immediate. And curiously, every technique works well on the first joint, the MCP joint, metacarpal phalangeal joint. So I just say, if you're learning for surgeons to do it, or patients don't mind doing the first joint, relieving that, the nerves and everything are deep. It gets trickier as you go down the finger and the PIP joint, but doctors with experience are comfortable doing that. I've also been, you can do multiple fingers, but it's trickier. The PIP joint, the middle joint of the finger, is the trickiest, but it's useful. And the PIP joints are the hardest with surgery. They're the hardest with Xiaflex and the hardest with needle. So
Okay.
I will use a combined approach. And the little finger PIP joint is the worst. If your little finger has a 60-degree bend of the PIP joint, all techniques are going to be rough. And if it doesn't get straight with needle, it's not going to, you can get it straight at surgery, you can get it straight at enzyme, you can get it straight with needle. It just doesn't stay straight.
Yep. Yes.
And that's with splinting and therapy and everything. You're going to have some residual. I always tell people, if you do surgery, you're going to be a wounded puppy for a couple of weeks and your fingers are going to be curled up.
Right.
And then you tend to have some bend. And splinting, I'm a fan of splinting. However, the data doesn't show that it really makes much of a difference. I believe it would for PIP joints some, but it's not as good as we hoped. It's we have to do it.
Right. And it's so cumbersome.
We tell patients to splint, but whether they do or not, I'm a big fan of dynamic extension exercises.
Okay.
And so if you put a splint on a finger, that's a static exercise. I mean, you just splint it straight. Dynamic stretching is, I'll show you, Kurt, if you take my ring finger, let's say I have a bend like that in my ring finger. If I put my finger, I'm putting my finger between.
Okay.
You see my MCP joint is bent down about 30 degrees, and my little finger and middle fingers are straight. So I have my finger in back of my ring finger. If you stretch it, you can see that there's extra strength and it gives extra torque at the PIP joint.
Okay.
So that's called dynamic exercises. You can do that a lot because that's for the PIP joint. That's very important.
That's great. And you do that either pre-NA or Xiaflex or post as kind of part of it.
Once you get it released, you have to do that.
Okay.
Basically, you're flexing your MCP joint and straightening your PIP joint.
Okay. Wonderful.
If you look at what I'm doing, Kurt, when you straighten your fingers, your hand curls. That's natural. When you bend when you bend your first knuckles down, your fingers straighten. So when the first knuckle is bent, your finger's straight. When you straighten all your fingers, they naturally curl.
Right.
Like that's how our hands work. So if you bend your things, you notice how your finger's straight. So if you put your finger in there to bend it even more, it adds to the strengthening.
That's fantastic. Awesome. I love it.
Like that, exactly.
That's great.
And Dr. Lalonde has been a proponent of that.
Okay.
And I think it's been great. It's a useful adjunct. It's hard to do, but it's good, and that's the exercise I show people to do.
No, it's great because the splints are wonderful, but they're also. My dad just had his first fasciectomy after 7 different needle procedures, and he had the splint he had was like sizable in terms of wearing it, and just like you said, he had his pinky done, and within a few months he had sizable recurrence.
Well, you can also buy very inexpensive splints on Amazon, so that's really wonderful. Patients, you can get splints for $10 or $20, and they can be quite useful. And so
use what's the glove? Do you use the glove that's
the fixed glove? I like the fixed glove a lot. It's FIXXGLOVE.
Yes. Okay.
It's somewhat expensive. It's an excellent glove designed by a hand surgeon.
Okay.
But I think it's $90 or $100. You can get some more inexpensive gloves for $10, $20, or $30.
Okay.
So all of these, they're all useful. The fixed glove is a static splint, but people like it. Yes, I do recommend it.
Okay, good. Yeah, there's a growing amount of splints, as you mentioned, on Amazon. People text me all the time. Check out this one. It's a lot to go with my 35, 40 pairs of gloves.
How do I stay updated? Well, patients come up with ideas. I mean, I do participate in some of the patient forums, the British Dupuytren Society. Dr. Eaton sends out great stuff. With his Dupuytren Foundation, I participate in that. And I found another useful thing. I didn't realize this, but there's a condition. I rarely see it with needle. I saw it some with surgery called complex regional pain syndrome.
Okay.
Called CRPS, or another term is reflex sympathetic dystrophy. And I just found out that if people are getting that or starting to get that or a flare, Dupuytren's flare is sort of a mild form of that. But if they're getting the severe CRPS, They're treating people with a gram of vitamin C a day, and that seems to be the antioxidant effects of the vitamin C can help those. I haven't shared that in any of the forums yet, but I just saw that in my own research. So that helps people that are getting pain syndromes after surgery. Sometimes needle. I've had just a couple or a few in needles.
Wow. Just 1 gram vitamin C orally?
Speaking of, if people have had a pain syndrome after surgery, the CRPS or reflex dystrophy, I've done needle in their other hand successfully without that coming off.
Okay.
I've had a few people get it over 20 years of needle, but that's highly, highly unusual. I think it's more common with surgery because it's just a bigger insult to their...
Right.
There's so much more pain to start with.
Right.
I think when people wake up from surgery and suddenly they feel all that pain, it can just set off a pain syndrome. We use local anesthesia, so they don't have any pain for hours and hours, and even then it's mild pain.
No, yeah.
When you cut the skin, you have pain. When you poke the skin with needles, you don't really have pain.
Yeah, I've never had pain, but I know a really good doctor up in Larkspur that does my hands.
For patients, they can go to this site called Google Scholar.
Oh, yeah, okay. It's a great tip.
Google Scholar is where the doctors publish their papers. And unfortunately, you can only read the abstracts, although some can be completely free. Like I have a paper called Dupuytren's Tips and Tricks. It's totally free, and that can be a good springboard for patients for education. In that paper published a few years ago, it's free online. It's Dupuytren's Tips and Tricks by Keith Denkler and my associates at UCSF, and we just give some ideas in the surgery, non-invasive, and just different techniques. There are some videos there, a simple needle, highly advanced needle, but that's a good starting point. But the patients need it.
It's a wonderful paper. I love that paper.
We don't want you to go to sites where people are selling you something. We want you want unbiased,
information.
Opinion.
Yeah, no, it's a wonderful paper.
And I'm not wedded to any particular technique. Surgery, enzyme, and needle, they're all fine. They have their roles.
Situational.
And radiation has its role. So I refer people to radiation. I refer some people to surgery. I'm here to help.
I love it. Well, you do that. So I found you. I think I found you over a video. I sent you years ago a picture of my finger because I couldn't find anybody to work on it, given it was middle finger, middle joint, digital nerve was, in proximity. So I found you through a lot of the online patient groups as just a patient advocate, dedicated expert. So I'm glad to know you. I'm glad to have you as my friend and my also surgeon when I need it. So it's wonderful. So I thank you greatly for doing this and sharing your pearls of experience and expertise. And thanks for all you have done for this community and will continue to do. So I really appreciate you sharing and taking some time today for the audience. Thanks again for listening to today's show, and special thanks to our show's sponsor, Vontu Biosciences. Should you have additional questions, topics, or show ideas, please don't hesitate to reach out. We'll do our best to make sure we get them on a future show. Thank you, and thanks for listening.